Hello everyone. We are going to talk about hemodynamic monitoring and arterial lines, all types of pressure lines. This will be broken up into a couple of recordings. The first one will be on hemodynamic monitoring. Then there's going to be a quick guide for hemodynamics that you should look at after this one to help you put it together, be able to get all of this stuff out, and then the final recording will be of arterial lines. So this is falls under the concept of perfusion and those subcategories, which I name preload, afterload, and contractility, and those terms should be familiar to you because that is actually what you see in your pharmacology book. So we're going to dive in. There's also a fast fact for you to look at to get the basics of what we're talking about. This is all about the heart beating and really specific parameters we can monitor. This is done in the ICUs. That's really the only time that you will see this. Can be done in surgery. Possibly a step-down unit might have an arterial line, but very specific. And these are really used for our very sick patients, our post-op patients, like our post-op heart patients who've had bypass, and then very sick patients who are what we like to call hemodynamically unstable. And that's a very broad term, and you will probably hear lots of different, if you ask 10 nurses, you will get 10 different definitions of what that is, but very good so that we get real specific data. What I want you to remember, though, is you have to correlate this data with your patient and that assessment of that patient. We don't just treat the monitors and the numbers, we do treat a patient. So we need to correlate that because as we talk further, especially about arterial lines, we could have an error in the system. And if you just look at the numbers, you'll treat the patient for something that they don't have. So don't worry about that. You'll get good with that. So it's all the data we take in. We got to recognize these cues. We got to analyze it, and then we've got to come up with what's going on. Okay, so let's talk about what this is. Hemodynamic monitoring is used to assess and trend the accuracy of tissue perfusion, hence the category of perfusion. It does aid in detecting an impending cardiovascular crisis, so we can see things coming in advance before the patient gets really bad and is on the verge of needing for us to call rapid response or a code. And it does guide our therapy because instead of thinking, all right, my patient has a decreased cardiac output problem, and that means that I'm going to have weak, thready pulses and poor cap refill and cool, pale skin, it would take a while for those signs and symptoms to get better. As I give patients medications, I can look at these numbers that adjust within minutes. They update all the time, if not constantly, and I know exactly what I'm doing. So we are looking at the physiological relationship between heart rate, blood flow, and oxygen delivery. So we've got to have all that come together. So we do have some non-invasive ways to do this, and that's blood pressure. That tells me about hemodynamics. If your blood pressure is 60/40, you have poor cardiac output, and you probably are not making any sense, and you don't have, your cap refill is very prolonged, you have weak, thready pulses, and you're having a hard time. Jugular vein pulse can tell us about that, and actually lactate or lactic acid, which we use in sepsis, and hemodynamic monitoring is fantastic, and sepsis will also help in that. Our invasive lines are these hemodynamic monitoring lines that we'll talk about in a subsequent recording. Okay, so let's jump in. Here's the things you need to know. Preload, afterload, contractility, and I'm going to go one by one. So when you hear the word preload, you need to think of volume. It's the amount of blood in the ventricle at the end of diastole. It's when that ventricle is the fullest just before it squeezes. And we're going to measure it with CVP, and CVP is actually a right-sided pressure, so it's measuring over in the right ventricle, and normal CVP is 2 to 6. It is not very high. Afterload is the resistance of blood that this blood has to overcome to deliver this blood or stroke volume out to the tissues. So what afterload is, it's measuring the resistance that the ventricles have to overcome. Specifically, we're going to talk about the left ventricle. So the pressure out in the body, think of diastolic blood pressure, that's the pressure that the ventricle has to overcome to get blood out. The amount of blood that comes out per beat is called stroke volume. Normal stroke volume is 60 to 100 mils per beat. But when we talk about afterload, we're talking about that resistance. So how much resistance or how little resistance do I have to get this blood out? And it is measured by SVR, systemic vascular resistance, because that's the left side, because it's the systemic circulation the left ventricle is pumping against. We can measure the right side, which is called PVR, pulmonary vascular resistance, and we did talk about that in congenital heart defects. But for this, we're going to keep it to the left side. And normal SVR is 770 to 1500, and it's actually measured in dynes, which is a funny little measurement. Don't know what it is. I just like to say it, and I know how to spell it. And then we're going to talk about contractility, and that's the heart's ability to pump blood out to the system. And it's measured by two things: cardiac output. And we've already talked a lot about cardiac output. And cardiac output is 4 to 8 liters per minute. And then cardiac index is 2.5 to 4.2. And cardiac index is more specific because the patient's height and weight is taking into consideration, so the body surface area, so it will adjust to that. Those two are married. They do go together. You don't see one up, one down. If one's down, they're both down. If one's up, they're both up. And they go together. And this is all about pumping. Okay. Take a deep breath. Think about these for a minute. Write this out. This is the basic principle. Preload is volume. Afterload is resistance. And contractility is pumping. All right, so let's talk about treating preload. Preload is the volume of blood at the end of diastole. The ventricles are at their fullest, and we're going to think volume. And when I have a preload problem, I either have not enough volume or I have too little volume. And our normal value is 2 to 6. So if my CVP is less than 2, then I have low volume. If my CVP is greater than 6, then I have too much volume. So I have fluid volume overload. And when you think of these numbers, you need to think about what the patient's assessment would look like if I'm in fluid volume overload. I always think heart failure. They have fluid volume overload. Well, what are they like? They have crackles. They have edema. They have too much volume. If my CVP is low, that's somebody with fluid volume deficit. So that's somebody who is dehydrated. They have poor skin turgor. They have poor urine output. They've got tinting of their skin. So when you understand that, then you understand how to treat CVP. So to increase your CVP, that would be because your CVP is low, you're going to replace the volume. And the very first thing we do with volume, whether it's too high or too low, is the easy stuff. We give fluid or we take fluid away. So if I need to increase their preload because the volume is low, then I need to give them fluid, and we will give them normal saline or LR. So my dehydrated patient who's had nausea and vomiting and diarrhea for 5 days is going to get fluid boluses. Then I can use things like volume expanders like albumin. Very common to have post-op hearts get albumin to help expand the volume that they already have so that they've got more volume. We're going to give them blood products if they need blood products because this is a trauma patient who's bled out or a GI bleed or whatever the cause is that they're having bleeding. They need blood products. And then after that, after I filled that tube, then I'm going to squeeze that vessel and give them a vasopressor, such as norepinephrine or epinephrine. But you always have to fill the vessel before you squeeze it. If you don't, and you squeeze a dry vessel, you don't get anywhere. You don't make your patient better. Now, to decrease my preload, because my CVP is high, I need to decrease that circulating volume. So I'm going to do the easy stuff first. I am going to give them a diuretic. And if you give a diuretic, The most common diuretic we give is furosemide. You should check a... All right, I left a big blank, and hopefully you said the correct word because I've already talked about it a lot and you need to know that. So I'm going to give them a diuretic. After that, I am going to work on the vessel, and I'm going to do the opposite of what I did if my CVP were low. I'm going to dilate that vessel to help displace, so dilate to displace the extra fluid. And my vasodilators are nitroglycerin and nitroprusside. Now, side note, morphine is a vasodilator. It dilates your coronary arteries. That's why we give it to you when you're having an acute MI, so we can get more oxygen to your heart. We can also give it to you if you're having pulmonary edema because it will help dilate those vessels, offload some of that fluid, and calm you down when you're having trouble breathing. But the two big ones you need to think of, because when we're talking about hemodynamic monitoring, we're talking about these IV drips, vasoactive meds, whether they're vasoconstrictors or vasodilators, and they are usually dosed in mics per kilo per minute. So that's nitroglycerin and nitroprusside. All right, let's talk about resistance. This is the pressure that out in the vessels that the ventricles have to overcome to get blood out. Because if my diastolic blood pressure is 110 and my heart can't generate enough pressure over 110 to get blood out, blood didn't go anywhere. And when you think of afterload, this is really about vasodilation or vasoconstriction and what those vessels look like. So if I have a high diastolic blood pressure, I would have a high SVR, and I would have a really tight vasoconstricted vessel, which means it would be much harder for blood to come out. So I put little dots here. You can think of these like straws. A normal vessel that has an SVR of 770 to 1500. It's coming off the left ventricle, that's a big pumping chamber out to our body, so it's a great big number. And that's a regular sized drinking straw. Now, if I need to increase my SVR because my SVR is low, that means that vessel is big. It's a boba straw. And a bigger vessel doesn't mean blood's coming out any better. That means I have too much vasodilation. And they're going to have signs and symptoms like low blood pressure, decreased urine output, decreased SVR, because the vessel's so big. So what do? This is all about the vessel. And if my vessel is too dilated, I need to vasoconstrict it. So you can open up your hand really big and then make a fist, and that's a vasoconstriction. And what are those vasoconstrictors? Epinephrine, norepinephrine, phenylephrine, the big daddy vasopressin. Those are our vasopressors. If I need to decrease my afterload, my SVR is too high, that is hypertension. I have a teeny tiny little vessel, which means it's very hard for the heart to get blood out. I need to vasodilate to make it easier. And guess what? The vasodilators didn't change. It's nitro and nitroprusside. So nitroglycerin and nitroprusside. Going to give all of these as a drip through an IV. Really should be in a central line, and we are going to monitor their vital signs every 15 minutes. Okay, let's talk about contractility. This is the heart's ability to pump. And cardiac output is made up of heart rate times stroke volume. Stroke volume is how much blood comes out per beat. So it's a simple math formula. The faster my heart beats, the more cardiac output I get. The more blood that comes out, the more cardiac output I get. Anything that changes heart rate or stroke volume will affect cardiac output. So cardiac contractility is measured by CO, cardiac output, 4 to 8 liters per minute, and cardiac index 2.5 to 4.2, which is more specific based on their BMI. Here's your little blurb about stroke volume. There are instances where we will measure just stroke volume, but we're really going to focus on COCI. But what I want you to understand is look what stroke volume is made up of. Preload, afterload contractility. They are all interwoven. So if I have poor stroke volume, I could have a preload issue, I could have an afterload issue, I could have a contractility issue, or I could have issues in any and all of those. Okay, so let's talk about treating contractility. The only thing we're going to focus on is increasing contractility. Are there cases where we have high COCI? There are. We treat those patients with antihypertensives. But for the purposes of what we're talking about people who are hemodynamically unstable, and that is people with low cardiac output and low cardiac index. So think of cardiogenic shock, because this hemodynamic monitoring is so important and will help you. If you get these meds down, you know how to treat all these shocks. So we need to improve the contraction of the heart, and we give them inotropes, or some books refer to them as cardiogenic glycosides. And I believe that's what your book uses. Inotrope is kind of the easier term to think of. And there's 3 of them: milrinone, dobutamine, and dopamine. Fun fact, people can go home on a milrinone drip. People with poor contractility, usually having severe heart failure, and some of these patients are waiting on the transplant list, and they go home with this med, and if they don't feel well, they call, and then they're told how to adjust their own meds. And these are meds that I run in mics per kilo per minute, watch them like a hawk in the ICU, and take their vital signs every 15 minutes. So, little fun fact there. One thing about dopamine increases heart rate. Cardiac output is heart rate times stroke volume. So if my heart rate goes up, my cardiac output goes up. And that can be really good, except for, think about this. What is the compensatory mechanism to low cardiac output? It's increased heart rate. That is a natural phenomenon of your body. If you have low blood pressure, low cardiac output, your body, your baroreceptors will send the message to your brain to say, increase the heart rate so I have better contractility. These patients who are hemodynamically unstable may already have a heart rate of 120. So dopamine may not be your best choice, because it will give them a heart rate of 140 to 150, which could be very dangerous for your patient. Also, what I want you to remember is, when you are studying your dysrhythmias, like 3rd-degree heart block, one treatment is dopamine, because it increases your heart rate. Okay, so that's it for this piece of hemodynamic monitoring. Be sure and take your notes, take a deep breath, look at this, and kind of study this, because you can get this down. The quick review will show you the easy way to study it and make it really stick in your brain. Thanks.